Hello, friends. I am Dr. Ajay Yadav. So, we are going to discuss today one short revision. And just let me see connection at uh, YouTube. Just give me a second. Let me see. Hello. We are going to discuss today one short revision. Okay, fine. It's going well. So we can start. Uh, so queries we'll take in the end. So I'll not see in between. So whatever your queries, you please keep on posting. And in the end, I'll take all those queries. Fine, or you can note it down. Later also, we will take up these queries. Fine. So at the end. So regarding as far as notes, it's okay if you want to hear, that's fine enough. And even if you want to note down, that is fine enough. But even if you don't want to note it down and just listen and understand, that should be fine. Because, but yeah, I don't think it is possible to give annotated PPTs in some way for students who are not enrolled. So anyway, let's see. So let's start with history. Everything in the world, in life starts with history. So let's start with history. And in history, the two most important things, or two most important point that you should know, that first public demonstration of, you can say, general anesthesia was given by Morton, and that was given on 16th October. And that is why today we are celebrating 16th October as World Anesthesia Day. So first public demonstration of GA, and this was actually given with ether. Ether. So first public demonstration of, you can say, ether anesthesia or general anesthesia was given by Morton, and that is on 16th October. So this is a very important, you can say, date 16th October, because even today we are celebrating World Anesthesia Day on 16th October. Then another very important landmark is the first panesthesia in human beings, and that was given by August Bayer. August Bayer, and it is a very interesting story. You know what the subject? He subjected himself for the first panesthesia, and it was given by uh, one of his friend and colleague. She was physiologist, and you know that when it became successful on his friend, that physiologist, then he gave to her. So these are really something big to try on yourself, and that is why we are remembering them. So these are the two most important point in history, which you can remember. That first public demonstration of GA by Morton, and first spanesthesia by August Bayer. Then anesthesia delivery systems. So as the name suggests, means the systems which are used for the delivery of anesthetic agents. So anesthesia delivery system, just try to understand in a manner that there should be a source for the gases. From source, these anesthetic gases will reach the anesthesia machine, and from anesthesia machine through tubings, or you can say circuits, they are going to reach the patient. So through these breathing circuits, or you can say anesthesia circuit, they reaches the patients. So that's a, you can say, chain of anesthesia delivery system. So first let's see the source. Source may be cylinders. And regarding cylinder, two most important thing that you must know is, one is the color and second is the pressure. And color is not only important from questions point of view. Color is very important from clinical point of view also, because color is the only criteria to identify cylinder. So if you know the color, then only you can identify a cylinder. So color of oxygen cylinder is black body with white shoulders. So you can see also black body with white shoulders. and pressure is 2000 psi. Although there are many units being are used for pressure, numerous units of pressure being used, but the most important unit that you should know and for which you expect question in that unit is pounds per square inch, that is psi. So in a full oxygen cylinder, the pressure is 2000 psi. Second cylinder in common use is nitrous oxide, which is stored in blue color cylinders. You can see blue cylinders. This is also nitrous oxide, but due to some shade, it is not looking like blue, but it is actually blue. So this is clear blue, you can say. Blue, and the pressure is 760 pounds per square inch. So nitrous oxide is stored in blue color cylinders at a pressure of 760 psi. Third cylinder, which you should know and sometimes ask, is Antonox. Antonox. So Antonox is a mixture of 50% oxygen and 50% nitrous oxide. So Antonox is a mixture of 50% oxygen and 50% nitrous oxide. So it is stored in cylinders with blue body and blue and white shoulders. So blue body and blue shoulders, this is blue body and blue shoulders, this indicates nitrous oxide, while white shoulders indicates oxygen because it is a mixture of nitrous oxide and oxygen. So blue body with blue and white shoulders, and the pressure is 2000 psi, means they are exhibiting the pressure of oxygen. And that's a very simple rule of physics. You know that when you mix two gases together, the combination will always exhibit the pressure of higher gas. That is why Antonox is exhibiting the pressure of oxygen, that is 2000 psi. So there are many other cylinders also, but of course you need not go in all those details. These three are more than important, you should know. Most important being, I will say, oxygen, black body with white shoulders. So that is the max, most probably you can say question you can expect. The color of oxygen cylinder, black body with white shoulders, and the pressure in a full cylinder is 2000 pounds per square inch. Nitrous oxide stored in blue color cylinders at a pressure of 760 pounds per square inch. Antonox, which is a combination of 50% oxygen and 50% nitrous oxide. So blue body with blue and white shoulders, blue body with blue shoulders indicating nitrous oxide and white shoulders indicating oxygen, and the pressure is 2000 pounds per square inch, that is the pressure of oxygen. Then another very important thing that you must know about cylinders, which is partially a part of cylinder and partially is the part of anesthesia machine, is pin index system. So pin index system is the system which is used to prevent wrong fitting of cylinders to anesthesia machine. It is possible that if you fit wrong cylinder to anesthesia machine, you fit say nitrous oxide cylinder at the place of oxygen and patient receive 100% nitrous oxide, patient is definitely going to die. So therefore there should be a system which should prevent the wrong fitting of cylinders, and that is pin index system. So what this pin index system is, they have devised actually 7 pin positions, 1, 2, 3, 4, 5, 6, 7. Now we say that pin index for oxygen is 2,5. Pin index for oxygen is 2,5. What does that mean? That means at the part of the anesthesia machine where cylinders will be fitted, that part of anesthesia machine is called as yoke. So at that yoke, there are two specific defined positions for each cylinder. Like say, for example, this is, I will say, yoke of oxygen. So what should be the position of these two pins? 2 and 5. Now at the corresponding in cylinder, the holes will also be at same position. Now say if this is a oxygen cylinder, The two holes will be at a position of 2 and 5. Now pin index for nitrous oxide is 3, 5. So I say if this is a yolk of nitrous oxide, then the pinpoint positions will be 3 and 5. And say if this is a nitrous oxide cylinder, then the pin positions will be 3 and 5. So will you be able to fit nitrous oxide cylinder at the place of oxygen? Of course not, because pins and holes will not match with each other. So you will not be able to fit one cylinder at the place of other, and you can really prevent catastrophe. So therefore, pin index system is a very important protective mechanism which is there to prevent the wrong fitting of cylinders. And pin index position for different gases you have to remember. Oxygen, the two pins defined are 2 and 5. Nitrous oxide, 3 and 5. Actually, air, 1 and 5. But air is actually supplied through central supply. So I did not mention, hardly you see any cylinders for air. So therefore, there is, if you want to skip also for air, that's fine enough. And Antonox, there is only single pin at a position of 7. So pin index system is a very important protective mechanism to prevent the wrong fitting of cylinders to anesthesia machine. And pin index position for different gases. Oxygen, the pin positions are 2 and 5. Nitrous oxide, sorry, it is 3 and 5, I think. It's a printing error. So you can correct it. Nitrous oxide is 3 and 5, not 2 and 5. 2 and 5 is oxygen. So this is a typing error. So 3 and 5. And air, if you want to remember, fine, 1 and 5. If you want to skip, that is also fine. Antonox 7, although Antonox through cylinders attaching to anesthesia machine is also not supplied. So 90%, 95% or 99% you are expected to know the pin index position of oxygen and nitrous oxide. Oxygen 2,5 and nitrous oxide 3,5. Now I told you in larger hospitals there is a second source also, that where consumption of gases is more, it is not possible to change cylinder every time. So there, these gases, they are supplied through central supply. This oxygen, nitrous oxide, and air, they are supplied through central supply. There is a central supply room having very big cylinders or tanks. Through them, through central pipes, these pipes will be delivered to operation theater where you can connect to anesthesia machine. So through central supply, all these three gases, that is nitrous oxide, oxygen and air, they are supplied at a pressure of 60 pounds per square inch. In your books, you will find either answer given is 50 psi or 55 psi, depending from which source they have picked, because in US it is supplied at 50 and UK it's supplied at 55. So depending on from which textbook they have picked, so answer you may find 50, 55. But in India, the central supply is at a pressure of 60 psi. So you have to know you have to mark the 60 psi. So this is all about source. Fine. This is all about source. Now just let me see any some technical glitch or something. Just let me check. Okay, fine. So there's no technical glitch. So source. Now from source, gases will go to anesthesia machine. And anesthesia machine, what happens? Three things that we do in anesthesia machine. One will be pressure reduction. Pressure in cylinders and central supply is very high. It is not possible to give that much pressure, so we have to reduce the pressure. And how much liters flow we should give, we can set that flow rate also. So we set flow rates. And third thing is we add volatile agent. We add volatile agent. So from sources, gases come to anesthesia machine. And three things what anesthesia machine do. There are many things, but from your point of view, basic in anesthesia machine, the pressure will be reduced. And then we can set the flow rate that how much liter we want to give. And we can add any of a volatile agent, halothane, isoflurane, desflurane, whatever we want to use. Now, from anesthesia machine, gases will be delivered to the patient through circuits, that is breathing circuits. So breathing circuits are nothing. These are the connections which connect anesthesia machine to the patient. So let's see about breathing circuits. Breathing circuits, we'll going to discuss the commonly used breathing circuits. So breathing circuits broadly you can say can be classified as semi-open and open. Semi-open, open or semi-closed and closed. Open means you directly pour inhalation agent over patient mouth and nostril. So this was more or less applicable for ether, but you cannot control that how much exact percentage is going. So actually open is obsolete. So what nowadays we are using is semi-open, semi-closed or closed. So semi-open circuits, they were described by the scientist Maffelson. So they are called as Maffelson circuits. So semi-open circuits. So maybe in books, you may find Maffelson circuits being defined under semi-closed previously, but now there are some new changes in classification. So we'll not go in that much details. But yes, now Maffelson circuits are being classified under semi-open. So Maffelson described actually 6 types of circuits, you can say A to F. Maffelson A is also called as Magill circuit. So this is the Magill circuit and it is the circuit of choice for spontaneously breathing patient. See, when you are giving anesthesia, there may be controlled ventilation. Controlled ventilation means you have paralyzed the patient by giving muscle relaxant and you or ventilator control the ventilation of the patient. So, or secondly, the patient may be on spontaneous breathing, but this is rare. Mostly it is controlled ventilation. We give muscle action to paralyze the patient and patient is on controlled ventilation. So if the patient is on spontaneous ventilation with Magill circuit, fresh gas flow. Fresh gas flow means the flow which is coming from anesthesia machine should be equal to minute volume. Means what is the minute volume? Respiratory rate into tidal volume. How much is the respiratory rate? 12. Tidal volume 500 means around 6 liter. So if you are using Magill circuit, means if the patient is on, say you have decided to use semi-open circuit and you are planning to keep the patient on spontaneous ventilation. So which circuit you are going to choose? Magill. And how much flow from anesthesia machine you are going to keep? That is 6 liter. That is why I told you we have to set the flow rates and we can set flow rates with anesthesia machine. So if I'm using Magill circuit, I'm going to use 6 liter for an adult patient. Then B and C were obsolete, they were not effective, so they become obsolete. Then Maffelson D. Actually, a modification on Maffelson D was made by scientist Bain. So as such, Maffelson D was not an advantage. However, a modification was made by scientist Bain. So Bain is a coaxial circuit. Coaxial means what he did? He incorporated an inner tube into this outer tube. You can see inner tube going all along the length, and this inner tube will be attached to anesthesia machine. So fresh gas flow will come through the inner tube. So means and expiratory gases through outer tube, so there will not be any mixing. So circuit actually become very popular so and so that you can say that Bayes is the most commonly used semi-open circuit. So Bayes is the most commonly used semi-open circuit, and it is the circuit of choice for controlled ventilation. And I told you controlled ventilation means you have paralyzed the patient. Patient is completely paralyzed and ventilator is controlling the ventilation of the patient. And fresh gas flow, if you are using it Bain circuit for controlled ventilation, fresh gas flow should be 1.6 times of minute volume. 1.6 times of minute volume means 1.6 times into 6, around you can say 9.6 liters. So you will be setting a flow of 9.6 liter, around you can say 10 liter from anesthesia machine. Then pediatric, other two, Mephelson E and Mephelson F, are pediatric semi-closed circuit. But Mephelson E was just a T-piece described by the scientist Ayres, but it was a complete circuit. So obviously, if not a complete circuit, incomplete, so obviously it is not used. Then some modifications were made by Mephelson E. In Mephelson E by two scientists, Jackson and Rees. And that is why Jackson and Rees is called as Mephelson F. And Mephelson F, you can say, is the most commonly used pediatric circuit. So Mephelson F or Jackson Rees is the most commonly used pediatric circuit. Then semi-open or semi-closed. Semi-open, semi-closed means you can clearly see the expiratory, there is expiratory limb, this is inspiratory limb, this is expiratory limb. And so what will happen? These expiratory gases will pass through this canister containing soda lime. So what this soda lime will do? It will absorb carbon dioxide, and the same gases can be reused by the patient. Means the same gases are in circulation, so they are also popularly called as circle system. Same gases are in circulation. So one of the very important, you can say, component of circle system is soda lime. Soda lime. One of the very important component of circle system is soda lime. And what is the composition of soda lime? Actually, there is a little change in recently, so I will change it. And see, whatever is the recent change, I'm going to use green pen. So if I'm using green pen, that means it is the recent change. So this is a recent change. And what is the recent change? I will tell you. Calcium hydroxide is 80%, sodium hydroxide is 3%, potassium hydroxide is 1%, and water is 15%. And there is a color indicator which tells whether the soda lime is fresh or has been exhausted. And different companies may be using different color indicator. So change is previous, if you see previous questions, you will find that it is given calcium hydroxide is 94% and there was no water. However, the recent soda lime, they have reduced the calcium hydroxide to 80% and the remaining volume is replaced by water around 15%. So that's a major change you can say. Now, so what I will ask you, what is the most important advantage of circle system? Same gases are in circulation. Means we are utilizing the same gases, so very low flow is required. In See, we just need to replace the oxygen consumed by the body. Otherwise, the same gases are in circulation. So therefore, we require very, very low flow. And so that makes this circuit to become very economical. Consumption of gases is so low that the same gases in circulation, so that these circuits really become very, very economical. Then Disadvantage, one of the major disadvantage of closed circuit, I will say, is that this soda lime, it can react with toxic compounds to produce, it will react with inhalation agent to produce toxic compounds. And the most classical example of that was trilene, but it is a matter of past. Trilene, by reacting with soda lime, used to produce toxic compounds which could have caused neurotoxicity or even which could have caused ARDS. But it is a matter of past. I told you now trilene is obsolete for decades and decades. But the agent which we are using nowadays, they can also react with soda lime to produce toxic compounds. For example, sevoflurane. Sevoflurane, by reacting with soda lime, produces a toxic compound called as compound A. Desflurane, with desiccated soda lime, not with the normal soda lime, with desiccated. Desiccated means if soda lime become very dry, then desflurane with soda lime can produce carbon monoxide. Similarly, with desiccated soda lime, sevoflurane can cause burns of the respiratory tract. So both of these complications are obviously not acceptable at any cost. That is, carbon monoxide poisoning with desflurane and burns with sevoflurane, of course, are not acceptable complications. But fortunately, the possibility of these complications are very rare. Why? Because the possibility of soda lime getting desiccated is very rare. Why? Because when soda lime react with carbon dioxide, there is production of water, and this water prevents soda lime to become desiccated. So just to rapidly summarize, circuits, breathing circuits nowadays used are semi-open and semi-closed or closed. Semi-open circuits were described by Maffelson, and he described from A to F. Maffelson A is called as McGill circuit and with the circuit of choice for spontaneous ventilation, and fresh gas flow required is equal to minute volume. B and C are obsolete. A modification of D Baines is the most commonly used semi-open circuit, and it is the circuit of choice for controlled ventilation, and fresh gas flow required with Baines circuit is 1.6 times of minute volume. Maffelson F, also called as Jackson-Rees, is the most commonly used pediatric circuit. Closed circuit or semi-closed circuit, which are also called as circle system, they are preferred actually because they need very low flow and that makes them very economical. So definitely they are preferred over semi-open circuits. And the major component of soda lime is calcium hydroxide, 80%. Then some of the inhalation agents, they can react with soda lime to produce toxic compounds. The classical example was trilene, which used to produce toxic compound, which could have caused neurotoxicity or ARDS, but I told you it's a matter of past. However, the agents which are available today, they can also react with soda lime to produce toxic compound. For example, sevoflurane produces a toxic compound called as compound A, which is a nephrotoxic agent. Then with desiccated soda lime, that is dry soda lime, desflurane can produce carbon monoxide and sevoflurane can cause burns. But I told you these are actually the rare complications. So that's all about anesthesia delivery system. Now let's discuss about equipment. And equipments actually are very commonly asked nowadays because these anesthesia equipments are mostly related to ventilation, resuscitation. So they are being very, very commonly asked if you see the trend of last few years. Very commonly asked. EMBU, stands for artificial manual breathing unit. Artificial manual breathing unit. And this is of course used for ventilating the patient during resuscitation. and it is possible to deliver 100% oxygen with embo bag if there is a bag, reservoir bag, and there is a oxygen source. So if you connect to any of the oxygen source and there is a reservoir bag in the back, it is possible to deliver almost 100% oxygen with embo bag. Gudel's airway, one of the very important, I will say, airway equipment which is used to prevent tongue fall, because you know that the most common cause of airway obstruction in an unconscious patient is tongue falling back on posterior pharyngeal wall and obstructing the airway. So Gudel's airway is placed like that so that this portion lies in oropharynx. Oropharynx means between tongue and posterior pharyngeal wall. Thus, thus preventing tongue falling back on posterior pharyngeal wall. Then LMA, the most important device, I will say, on which very often you see questions, is laryngeal mask airway. Actually, laryngeal mask airway has completely revolutionized the resuscitation practice, ventilation practice in last, you can say, decade or half so. So LMA is like this. You can see a large tube is there. Then there's a large cuff which can be inflated with this pilot balloon system. And these are the ventilation ports which are used for ventilation. So this is LMA. It is placed blindly in oral cavity so that this portion lies in oropharynx. So this portion is oropharynx. So you inflate with large volume of air, so it will get inflated and will seal the oropharynx from all sides. Now, if you ventilate through this tube, through these ventilation holes, air has no option but to go to larynx. So if you ventilate through this tube, while this cuff has completely occupied the oropharynx, so if you ventilate through this tube, through these ventilation holes, air has no option but to go to larynx. So advantages, the major advantage I will say is you can avoid the complications of intubation. You can avoid the complications of intubations because intubation is associated with plethora of complications. So actually, when LMA was manufactured, it was manufactured as an alternative to intubation for difficult intubation. But over the years, when we started to use LMA, we found it to be so effective method of ventilation that now we are using it electively for ventilation to avoid the complications of intubation. So all complication of intubation you can avoid. But disadvantage, you know that it is not blocking the esophagus. Air can still leak from the sides, can enter the stomach, increases the intragastric pressure, increasing the risk of aspiration. So risk of aspiration is increased with LMA. That is the biggest disadvantage, that there is increased risk of aspiration. And another problem is, clearly you are seeing that air is getting leaked and patient stomach is getting distended. You cannot deflate the stomach because from where you will pass your suction catheter Ryle's tube. The cup of LMA has completely occupied the oropharynx. So from where you will pass your suction catheter Ryle's tube. So therefore, you cannot deflate the stomach. But this is not a problem nowadays because nowadays we are using second generation LMA. And second generation LMA, there is a separate tube for gastric deflation. So second generation LMA, there is a separate tube for gastric deflation. And the most classical example of second generation LMA is ProSeal. ProSeal. So ProSeal, you can see that there is a separate tube for gastric deflation. There is separate tube for gastric deflation. From this tube, you can pass your suction catheter Ryle's tube, and through this hole, it will enter the stomach and you can deflate the stomach. Then another kind of second generation LMA is iGel, which is very commonly used in India. The advantage is that it has a pre-filled cuff with gel. The cuff is pre-filled with gel. So all cuff related problems, by chance a cuff get deflated accidentally. So LMA can come out, can get displaced, can touch the larynx, inducing laryngospasm. So all these cuff related problems can be avoided because the cuff is already pre-filled with a gel. And it is a kind of second generation LMA. So you can see that there is a separate tube. Through this tube, you can pass your suction catheter as tube, and through this hole, it will enter the esophagus to deflate the stomach. Then another kind is LMA Supreme. LMA Supreme, you can see there are two advantages. The curve of the tube you can see, so that makes insertion easy. And secondly, there is a proper bite block so that patient will not bite the tube. If patient become conscious, he or she can bite this tube. Although in ProSeal they have also made it a little hard, but it's not a proper bite block. While LMS Supreme, you can see that there is a proper bite block. So LMA, very important device. Major advantage is that we can avoid the complications of intubation. However, major disadvantage is that increase the risk of aspiration. And nowadays we are using second generation LMA. They have separate tube for gastric deflation, and very commonly used or prototype is ProSeal. Then iGel has a pre-filled cuff with gel, very commonly used in India. And another kind of second generation LMA is LMA Supreme, which has a proper bite block. Face mask, just let me see if there are any technical glitch from technical team side. Okay, it's fine. No technical glitch, fine. Face mask. Face masks obviously are used for ventilation. However, they should be used as minimal as possible or as only a transient phase till you are not able to achieve definite airway. Definite airway means till you are able to intubate the patient or at least put laryngeal mask airway. Why? Because the biggest disadvantage of face mask ventilation is that there is tremendous increase in the risk of aspiration. Because when you are giving positive pressure ventilation with mask, a significant air will leak into stomach, will increase the intragastric pressure, increasing the risk of aspiration. So face mask tremendously increases the risk of aspiration. Laryngoscopes, obviously, laryngoscopes are used to facilitate intubation, and laryngoscope, the most commonly used is Macintosh. Macintosh is the most commonly used laryngoscope, and it has a curved blade you can see, and it is preferred for adults, but it is preferred definitely for adults, but that does not mean that we cannot use for children. It can be used for pediatric patients also, but preferred for adults. Miller, Miller is definitely, it's a straight blade you can see with a little curve at the tip, otherwise largely straight with a little curve at the tip, and it is preferred for children and I will say all age groups. And this is very important. Recent, so I will use green pen, all age groups. Previously, we were using different kinds of blade for different age groups, but nowadays, Miller can be used for all age groups. And again, I will tell you it is preferred for pediatric. but does not mean that it cannot be used for adults. It can be used, but of course preferred for pediatrics. So simply if they ask you laryngoscope blade of choice for pediatric patients, all age group, even newborn, it is Miller. If they ask you laryngoscope blade of choice for adults, of course it is Macintosh. Simplest, very simple. Then endotracheal tube. Of course, endotracheal tube is used for intubation. And endotracheal tube, you can see this is the machine end which will be connected to circuit or your bag, and this end will be the patient end. Fine. And the tube which we are using nowadays are polyvinyl chloride tubes, PVC tubes. PVC tubes are very commonly used. So this is a PVC tube, endotracheal tube. Now, what is the aim of the cuff? Why we inflate this cuff through this cuff balloon system? This is a cuff we inflate through this cuff system. So what is the aim of the cuff? I know many of you will say that cuff is used so that tube doesn't come out, but that is not correct. Cuff is only used to prevent aspiration. Tube should be fixed tightly at the angle of the mouth with adhesive plaster. So cuff is only and only used to prevent aspiration. Cuff is not used for tube fixation. Another very important change which has happened is that cuff tubes can be used in children. Again, I will say at any age. Very important change. Previously, so rather I don't mind if we can use green pen. Previously, we were not using cuff tube in children less than 10 years, considering that this subglottis is the narrowest part and tracheal diameter is narrow. So cuff can cause injury to trachea, edema to trachea or subglottic edema, but that all has been unfounded. So now at any age, you can safely use cuff tubes. The very important thing about intubation is you should know whether the tube is in right position or not. Means if you have wrongly placed the tube, if your tube instead of trachea, if it is in esophagus, then you are directly killing the patient. And you can use many methods to confirm that your tube is in right place. Like when you start ventilation, chest should expand. So you should be able to see the expansion. Then you can do the auscultation. You should be able to hear the breath sounds, but everything can misguide you. Even auscultation can misguide you. The tube may be in the esophagus and you are hearing the conducted sounds, which you can misinterpret it as breath sounds. So therefore, even auscultation can misguide you. So surest confirmation of intubation is only possible with capnography. So surest confirmation of intubation is only possible with capnography, which is the measurement of end-tidal carbon dioxide, or you can say expired carbon dioxide. And carbon dioxide will come out of endotracheal tube only if the tube is in trachea, otherwise from where CO2 will come out. So I think these are the very important things about basic equipment for resuscitation that you should know. Then preoperative assessment. So preoperative assessment is very important because uh, during preoperative assessment, we diagnose if the patient is suffering from any medical disease. Based on that, you can modify your anesthesia technique, and based on that, you can even medically stabilize the patient. So in that we take complete medical history, then we do examination, and in examination, particularly airway examination. And in airway examination, particularly I will say mouth opening. because you are going to intubate the patient through oral route, so there should be adequate mouth opening. And this mouth opening is assessed by modified Mallampatti scoring. So no need to go in details. Simply you can remember, in this what we do, we ask the patient to open the mouth as wide as possible. Then looking at the structure seen, patient has been classified into 4 categories. So class 1 means normal mouth opening and class 4 means no mouth opening. So obviously class 1 and class 2 mouth opening is adequate. So oral intubation should be easy. In class 3, mouth opening is restricted. So oral intubation will be difficult, and class 4 there is no mouth opening. So how oral intubation is possible? So it is impossible. So if oral intubation is impossible, alternative may be nasal route. You can intubate through nasal route. And even if nasal is not possible, then you can go for direct tracheostomy. So simply in ARF assessment, you can remember that modified Mallampatti scoring is used to assess the mouth opening. That should be more than enough. Then pre-medication. Actually, you know that previously we are pre-medicating the patient, all patients who are undergoing surgery with a lot of pre-medication drugs. But that does not happen in modern day practice. Modern day practice, they say pre-medication should be done with a clear-cut goal or clear-cut aim. There should be clear-cut goal or clear-cut aim to do pre-medication. And there are many goals, as I told you, but the most common goal in current day practice, if you will ask me, it is to relieve the anxiety. And for relieving anxiety, if you want to give some drugs, what should be the drugs? Of course, benzodiazepines, you are anxiolytic. And based on your institute practice, you can use any one, diazepam, lorazepam, midazolam, alprazolam, whatever you want to give. So that is the most common, you can say, indication to give pre-medication in current day practice, that is to relieve anxiety, and for that we can use benzodiazepines. Now another very important thing that you must know, and these kind of questions actually has been, I will say, rampant rise over the last few years, that if the patient is already on some drug therapy, what should be the modification you have to do, because these drugs, they can interact or they can have consequences in during surgery or anesthesia. So we have to either stop or we have to modify. So drugs which need to be stopped, Viagra or similar drugs, and the duration is to be stopped 24 hours before surgery. And actually, why we are stopping Viagra or similar drugs? Because you know that these drugs, they causes sympathetic stimulation, and surgery and anesthesia is a very stressful period. Very stressful period. So during that period, there if there is already elevated level of catecholamines, that can cause life-threatening arrhythmias. Anticoagulants, there are many anticoagulants which are being used nowadays, but the most basic that you know is warfarin. Warfarin, obviously we have to stop, otherwise patient will bleed. And warfarin should be stopped 5 days or 4 days. Actually, some societies follow 4 days, some 5 days. So both are acceptable. But if you get a choice between 4 and 5, question comes like that. Both 4 and 5 days are given, then you should choose 4. So if 5 days is an option, you can choose. But if 4 days is option, you can choose. But if the question comes 4 days or 5 days, then prefer 4 days. So anticoagulant warfarin should be stopped 4 days prior to the surgery. Antiplatelets. Antiplatelets are commonly used. Two antiplatelets are aspirin and clopidogrel. Aspirin should be stopped 72 hours before. This is a recent change actually, so I will use green pen. Previously, we were continuing aspirin, but in the patients in whom they continued aspirin, they found that the incidence of MI was not reduced, yet rather the incidence of bleeding was increased. So therefore, nowadays they say aspirin should be stopped 72 hours prior to the surgery, except in three situations: recent MI, recent stroke, and if the patient is coronary stent. In these three conditions, we are going to continue aspirin, else we have to stop aspirin 72 hours before. And clopidogrel, we have to stop 5 days before. So previous recommendation was also 5 days. So now also 5 days. So aspirin 72 hours and clopidogrel 5 days. Only recent MI, recent stroke and coronary stent, we will be continuing the aspirin. Oral contraceptives. Oral contraceptives only with high dose estrogen should be stopped 4 weeks prior. Why? Because you know that estrogen increases the risk of thromboembolism. So estrogen increases the risk of thromboembolism, so should be stopped 4 weeks prior. Herbal medications, again, this is a recent change, should be stopped 7 days prior. Because herbal medications, we generally think that they don't have side effects, but they actually have numerous side effects. And which side effects we don't know, because actually no studies are being done. So they have side effects, but which we don't know. So therefore, to avoid any such kind of risk, we are stopping all herbal medications 7 days before. AC inhibitors or angiotensin receptor blockers. AC inhibitors means enalapril, captopril, penidopril. ARB means sartans, valsartan, losartan, irbesartan, telmisartan. They should be stopped 24 hours. Again, change. So therefore, I'm using green pen because previously we were stopping them on the day of the surgery. But nowadays, we are stopping them a day before surgery. Smoking should be stopped 8 weeks prior. And why we are stopping smoking 8 weeks prior? Because smoking inhibits cilia and the complete recovery of cilia takes 8 weeks. Now, morning doses to be omitted for which medications? Three medications. Diuretics, important. If not taken for hypertension. If they are taken for hypertension, we will continue. But if they are not taken for hypertension, then we are going to stop diuretic on the day of the surgery. Topical creams. Why topical creams? Because these creams may have chemicals and surgeons are going to use so many antiseptic solutions. So these chemicals may react with antiseptic solutions, leading to skin reactions. Oral hypoglycemics should also be omitted on the day of the surgery. So diuretics, if not taken for hypertension, topical creams and oral hypoglycemics should be omitted on the day of surgery. Modifications required: cholinesterase inhibitors. That is neostigmine, pyridostigmine, and the problem is if you continue them, they can antagonize the effect of muscle action. If you stop them, patient can develop myasthenic crisis. So what is the modification? Use minimum doses. So they are reduced and used in minimum doses before surgery. Steroids, there are a lot of you can say guidelines for steroids. Will not go in that details, but you can say yes, steroids they may need some modification, and mostly modification is that patient will require perioperative steroids. So generally you can remember that patients who are in steroids, they need perioperative steroids. That's it. That's the modification you can say. ATT modification is required if LFT are normal. If LFT are abnormal, then we have to stop. If LFT are normal, we continue because ATT affects LFT. So if LFT are compromised, then we have to stop. So that is the modification that is required for anti-tubercle medication, ATT. Fluids. So intraoperative period, We need fluids either for maintenance or for replacement. Maintenance fluid preferred nowadays is ringer lactate, and I'm using green pen for all age groups, for all ages, and for all type of anesthesia. Previously, you know that there were different kind of fluid for pediatric age group, different kind of fluids for different kind of anesthesia, but that now all has been simplified, and nowadays fluid for all ages and for any kind of anesthesia is ringer lactate. And why we prefer ringer lactate? Because it is most near to body fluids. Replacement fluids means replacement fluid will be given as per the loss. So we will see how much is the blood loss, and that should be replaced with fluid. And again, for replacement fluid of choice is ringer lactate. So you can say fluid of choice for intraoperative period is ringer lactate, whether it is for maintenance or whether it is for replacement. Simple. Monitoring. Monitoring defines your quality of care. If your monitoring standards are high, definitely your quality of care is going to be good. Let me see any technical glitch from technical side. No, no message. Great. Monitoring. CNS. CNS, we do a lot of monitoring, but of course, from your point of view, you can just remember that for CNS, monitoring means monitoring the depth of anesthesia. We don't want patient to be very deep, and we don't want patient to be light anesthesia. And for depth of anesthesia, the most preferred nowadays is bispectral index monitor, BIS index. Bispectral index or BIS index. This you can say is the best monitor to see the depth of anesthesia, and very simple to apply. Just apply electrode over forehead and connect to monitor. Automatically, it will give you a score. And based on that score, you can know that how much is the depth. So bispectral index monitor, you can say, is actually the first scientifically validated and now very commonly used, freely available to see the depth of anesthesia. Cardiovascular monitoring. Cardiovascular monitoring may be simple pulse rate monitoring or blood pressure monitoring. Pulse rate is monitored with pulse oximeters. Blood pressure with obviously sphygmomanometers. But if you want to monitor continuous blood pressure, then we have to go for invasive BP, high BP. Invasive means we are cannulating one of the artery. And if you have cannulated artery, then it will give continuous measurement of blood pressure. And since it is a continuous uninterrupted measurement of blood pressure, so this invasive blood pressure monitoring is considered as gold standard method for blood pressure monitoring. So it's a gold standard method for BP monitoring. Second cardiovascular monitoring is ECG. This is a very important change. ECG actually we monitor two leads. Lead 2, because you know that arrhythmias are best detected in lead 2. So it's not possible to have 12 lead monitoring. So two leads which we are using are lead 2 and for arrhythmia. And you know that conventionally we were using lead 5 for ischemia, but recent evidence have found that V3 is better than V5 for monitoring the ischemia. Even in fact, V4 is even better than V5. So again, this is a very important question from recent point of view, because you know that until now, conventionally we were believing V5 to be the most sensitive lead for ischemia, but recent evidence have found that it is V3. Even V4 is preferred over V5. But the best is transesophageal echocardiography. All cardiac information, very sensitive to detect MI. You can measure all pressure of all cardiac chambers, volume of all cardiac chambers. You can see air if there is air embolism. So everything you can do it by transesophageal echocardiography. So as the name suggests, means the equipment is like esophagoscope, which is placed in esophagus, and that is we are doing continuous echocardiography. So since it gives every information, so you can say it is the best cardiovascular monitor. So transesophageal echocardiography, popularly short form TE, is a very standard term. So you may get even short form in exams also. So this is transesophageal echocardiography, which is best for intraoperative cardiac monitoring. Respiratory monitoring. Respiratory monitoring, the most basic respiratory monitoring is pulse oximetry, which measures the oxygen saturation, SpO2. So pulse oximeter measures oxygen saturation, and the normal oxygen saturation is around 97 to 98%. But one of the disadvantage of the pulse oximeters is that they cannot detect abnormal hemoglobins. Means if the patient is suffering from sulfhemoglobin, methemoglobin, they will not be, or even carboxyhemoglobin, they will not be able to diagnose. So they cannot detect abnormal hemoglobin. So that is a disadvantage of pulse oximeter. Capnography. Capnography is, I will say, uh, is the most sensitive respiratory monitor, and it is the measurement of end-tidal carbon dioxide along with the graphy, along with the graph. So a graph is also coming, and uses we have seen. It confirm intubation. We already have seen how it is confirming intubation means if the tube is in trachea, then only CO2 can come out of the endotracheal tube, which you can detect on monitor. Then, since it confirm intubation, so obviously it is the most sensitive to detect accidental extubation. Means if tube comes out accidentally, then what will happen in capnography? When the tube is not in trachea, from where CO2 will come out, which you can measure, so it will become zero, value will become zero, and the graph is going to become flat line. So EtCO2 becoming zero, or you can say graph become flat line. You can see the graph is coming like this, and then you see the graph become flat line. So obviously it is extubation, means tube is not in trachea, or there is no ventilation, apnea. If there is no ventilation, no CO2, so graph will become flat line. Disconnection means your endotracheal tube, if this endotracheal tube get disconnected from circuit, then how CO2 will reach the monitor? So it will again become zero. Or if your endotracheal tube get completely obstructed, there's secretion or kinking, complete obstruction, then EtCO2 can become zero. So imagine these conditions are life threatening. They will kill the patient. And these complications are detected within seconds. In the very next breath, there is no capnography, no zero value. EtCO2 is zero on monitor, and the graph is flat line. So that means these are the dangerous extubation, apnea, disconnection, or complete obstruction. So which can cause hypoxic brain damage or even can kill the patient. If you only rely on pulse oximeter, patient will show you oxygen desaturation even when the reserves of the body get finished. Reserves of oxygen means after a few minutes. While with capnography, you can detect these complications within seconds. So therefore, capnography is very sensitive, and in fact, I will say that it has completely revolutionized the anesthesia practice. General anesthesia. So what exactly we do in general anesthesia, just to understand what exactly we do. First, we pre-oxygenate the patient. First step is pre-oxygenation with 100% oxygen for 3 minutes. Why? Because we want to replace nitrogen from lungs and replace with oxygen, so that, say, if you're not able to intubate the patient or not able to ventilate the patient will be able to sustain hypoxia for a longer period, because now the lungs are filled with 100% oxygen. Once pre-oxygenation is finished, then induction is done with IV agents. And nowadays, IV agent most preferred is propofol. And why IV agents are preferred? Because they are ultra fast acting. They will make the patient to become unconscious within one arm brain circulation time, that is 15 seconds. Once patient fall unconscious, now we have to secure airway. So we have to intubate the patient. And for intubation, the ideal muscle laxant is succinylcholine, because it is also fast acting. Within 20 to 30 seconds, it will relax the laryngeal muscles, and then you can intubate the patient. After intubation, now you have to maintain anesthesia. Anesthesia is maintained with 75% nitrous oxide, or you can use air also instead of nitrous oxide, 25% oxygen, and one of the volatile agent, inhalation agent. And relaxation is not only required for intubation, muscle relaxation is required for surgeries also. So for that, we have to use long acting, and that is non-depolarizing type of muscle relaxant. Then at the end of surgery, you have to reverse the effect of these non-depolarizers by giving neostigmine. And then we are going to extubate the patient. So these are the things, this is the, you can say, methodology by which we give GA. Pre-oxygenate the patient, induce them with IV agents. Once patient become unconscious, we give muscle relaxant. Patient is relaxed, then we intubate and then maintain anesthesia with 75% nitric oxide or air plus 25% oxygen and one of the inhalational volatile agent. And relaxation for surgery is maintained with non-depolarizer. And the reverse of non-depolarizer, the action of non-depolarizer is reversed by giving neostigmine, and then patient is extubated. So let's see each of this in the same sequence. IV agents. IV agents, I told you they are used for induction. And why they are used for induction? I told you because they are ultra fast acting. So IV agents that are being used. Now, one question you will ask is, okay, why they are not being used for maintenance? For induction, patient become unconscious, then why we use inhalation agent for maintenance of anesthesia? Why not IV agents? Because all IV agents, they are actually metabolized by redistribution. What do you mean by redistribution? Redistribution means the drug will first go to the area with high vascularity like brain, and from there it will be redistributed to the area with low vascularity like muscle or fat. So they will leave the brain within 15 to 20 minutes. So they are still in the body, but left the brain, so patient will become conscious. So this is the reason that we can't use IV agents for maintenance. So IV agents, thiopentone, nowadays not used. And the most important reason for not using thiopentone is the long half-life. Half-life is 10.3 hours. Very long half-life means it is going to remain in body for such long time, for a day. So therefore, this is the most important reason for which thiopentone is not used. So other important points about thiopentone which you can remember is it has got highly alkaline pH. pH is again 10.4. Highly alkaline pH. Then redistribution is not only applicable for thiopentone. I told you that all IV agents are metabolized by redistribution. Then it is a very strong anticonvulsant. Actually, epilepsy not responding by any drug is finally controlled with thiopentone. So it is considered as anticonvulsant of last resort. So epilepsy not responding by to any drug is controlled with thiopentone. Then it can be used for cerebral protection. Why? Because it decreases cerebral metabolic rate by, you can say, around 30 to 40%. So it significantly reduces the cerebral metabolic rate by around 30 to 40%. Then one important complication of thiopentone, which you can remember, is intra-arterial thiopentone. And this intra-arterial thiopentone occur because of its alkaline pH, this complication. So what will be the complication? Actually, it is alkaline. So what will happen, and this is usually seen if it is given in antecubital fossa because of the close proximity of artery. So accidentally, if it is injected into artery, so this alkaline thiopentone will precipitate there, and this precipitated thiopentone. So this alkaline thiopentone will precipitate there, and this precipitated thiopentone can cause severe vasospasm, which can cause ischemia or even gangrene of hand. So this alkaline thiopentone, if precipitated, can cause severe vasospasm in the artery, and limb distal to the vasospasm become at risk of ischemia or gangrene. And I told you this is more commonly seen in antecubital fossa because of the close proximity of brachial artery. So the basically the event is vasospasm. So the management is obviously vasodilatation. And the most preferred vasodilator is papaverine. There are many vasodilators you can use. Phenoxybenzamine, phentolamine, even lignocaine, all vasodilators you can use, but the most preferred is papaverine to be injected locally at the same point where you have accidentally injected the thiopentone. Propofol. Propofol nowadays is most commonly used. It has almost completely replaced the thiopentone. So nowadays, for induction, most commonly used is propofol. So propofol is prepared in soybean oil. It's a oil-based preparation. Oil-based preparations means that is why it is painful. Oil-based preparation means it is painful. Then it contains egg lecithin. And egg, is a very good culture for bacterial growth. So there are chances of bacterial contamination, and actually there has been death reports also because of the septicemia, because of the use of contaminated solution of propofol. So therefore, propofol, while once opened, we have to discard within 6 hours. Very important. So propofol contains egg lecithin, which is a good culture media for bacterial growth. So propofol, while once opened, should be discarded within 6 hours. Otherwise, there can be septicemia, which can even cause death of the patient. Half-life 2 to 3 hours. This is the most important reason actually, for which propofol has actually completely replaced the thiopentone. Half-life is 2 to 3 hours. While thiopentone we have seen is 10 hours. Then another very, you can say, unique property of propofol is that it is antiemetic, and it's a very strong antiemetic. Not only that, it's a very strong antiemetic. So propofol is the IV agent of choice for routine induction and for daycare surgeries also. For daycare surgeries, we prefer the agents which should have short duration, short half-life, and we have seen propofol half-life is 2 to 3 hours, making it as an IV agent of choice for daycare surgeries. And otherwise also, I told you, for induction nowadays, it has completely replaced thiopentone from practice, and it is the agent of choice for induction also. Etomidate is the another agent which is being used for induction, and it is only actually used for cardiac patients because it is most cardiac stable. So it is the IV agent of choice for cardiac patients. It is the IV agent of choice for cardiac patients because it is most cardiac stable. But why we are not using it routinely when it is cardiac stable? Because of the possibility of adrenal suppression. Although this is not common complication, but when happens, it can be disastrous. So therefore, to avoid this possibility of adrenal suppression, we restrict the use of etomidate only for cardiac patients. Benzodiazepines. Benzodiazepines are mainly used in anesthesia for two purposes: as anxiolytics, and secondly to produce amnesia. There is another important role of benzodiazepines, that they causes you can say amnesia. They produces amnesia. And in intraoperative period, nowadays we are only and only using midazolam. Not rather, most commonly I will say rather we are using midazolam. And why we prefer midazolam? Because it has short half-life. Otherwise, diazepam, lorazepam used to have very long half-life. Half-life of midazolam is just 2 to 3 hours, while that of diazepam, used to be 36 hours, lorazepam 20 hours. So midazolam has shorter life. Therefore, nowadays in intraoperative period, we are only and only using midazolam. Ketamine is another agent that is used for induction, and ketamine produces anesthesia which is called as dissociative anesthesia. Dissociative anesthesia means patient not only get dissociated from surroundings, he or she get dissociated from himself or herself. That means you can say patient is in cataleptic state. Advantages. So ketamine, I will say, is a real unique agent which has certain clear-cut advantages and certain clear-cut disadvantages. So ketamine is the IV agent of choice for shock. Why? Because ketamine actually stimulates sympathetic system. And a stimulation of sympathetic system obviously will cause hypertension, making ketamine as an IV agent of choice for shock. Then it is the IV agent of choice for full stomach patients. Why? Because it preserves airway reflexes. So preserving airway reflexes means there is minimal risk of aspiration, making it as an IV agent of choice for full stomach patients. Then it is such a good bronchodilator that not only it can be used for active asthmatics, it can be used for the treatment of refractory status asthmaticus. And we are using, if asthma is not responding to any drug, you can try ketamine. So it is the IV agent of choice not only for active asthmatic, it can be used even for the treatment of refractory status asthmaticus. Side effects. The most important side effect actually for which ketamine, in spite of having such good properties, is not used because it can cause vivid reactions, which most commonly manifest as hallucinations. So vivid reactions or hallucinations, you can say, is the most important reason for which actually we restrict the use of ketamine only for specific situations, not as a routine. Second disadvantage, ketamine increases all pressures: intraocular pressure, intracranial pressure, or intragastric pressure. Intraocular pressure, intracranial pressure, or intragastric pressure. So all pressures are increased with ketamine. Opioids. Opioids, of course, are used in anesthesia for analgesia. Opioids, of course, are used for analgesia. They are analgesics. And the biggest, or you can say the major side effect of opioids is respiratory depression. And you all know that the most common cause of death in opioid poisoning is respiratory depression. Second disadvantage, I will say is muscle rigidity. They causes muscle rigidity. All these pure agonist agents, they can cause muscle rigidity, but maximally it is seen with L-fentanyl. L-fentanyl. And sometimes this rigidity may be so severe in thoracic muscle that the whole thorax become like wood. And sometimes to block that rigidity, we actually have to give even muscle relaxants. Then alpha 2 agonist also had been used in anesthesia, and two purposes of uses are they are used as an adjuvant to anesthetics, and they are also used to produce sedation. And actually FDA has recommended their use for sedation even outside the operation theatre. So alpha 2 agonist, they produce sedation. So obviously we are using them for sedation. Clonidine had been used in the past, but clonidine had many side effects. So therefore clonidine is stand obsolete. Nowadays alpha 2 agonist, which has lesser side effects, is dexmedetomidine. So dexmedetomidine has lesser side effects. That is why we are now routinely using alpha 2 agonist, that is dexmedetomidine. Let me see any technical glitch. Fortunately, nothing. Great. Okay. Inhalation agents. Inhalation agents, I told you they are used for maintenance of anesthesia. And two most important properties about inhalation agents that you should know. One is the potency. And potency of an inhalational agent is expressed by its MAC, that is minimum alveolar concentration. Means what is the minimum concentration which is required to produce the effect. So what is the minimum alveolar concentration we should be able to produce the effect that represents the potency. So potency is represented by minimum alveolar concentration. So regarding potency, just one or two points that you should know. They may ask, it is represented by the agent's minimum alveolar concentration, and most potent and least potent you have to know. So among the all agents which are we are using nowadays, so nowadays available agents I can say are nitrous oxide, which we are using, and it is a gas actually. Inhalational was gas. Then volatile agents of the current use, four volatile agents of current use are halothane, isoflurane, desflurane, and sevoflurane. So these are the four agents of the current use: halothane, isoflurane, desflurane, and sevoflurane. So most potent among these is halothane, and the least potent is nitrous oxide. Second important property of volatile agent that you should know is the fastest induction, and is the that blood gas coefficient indicates induction and recovery. Means how fast or how slow a agent is going to produce its induction is described by its blood gas coefficient. So again, you can remember that blood gas coefficient is the indicator of induction and recovery. Fastest induction is seen with xenon. However, xenon is not used. So second you can say is xenon. Although xenon is still not available for clinical use, it is still, I say, in experimental phase. But if they ask xenon, then of course xenon is the fastest induction, and slowest induction and slowest recovery is seen with halothane. Halothane. So now let's discuss important properties of these agents. Nitrous oxide. The most important property of nitrous oxide, which you can remember, is that it is 35 times more soluble than air. So what do you mean by that? 35 times more soluble than air means for 1 mole of nitrogen removed, it will be replaced with 35 molecules of nitrous oxide. Now imagine patient is having air in any of a closed space, like patient is suffering from pneumothorax, pneumomediastinum. So what will happen? For 1 mole of nitrogen removed, is replaced with 35 molecules of nitrous oxide. So imagine how fast a small pneumothorax is going to convert it into tension pneumothorax. So if there is any air in any of a closed space, whether it is pneumothorax, pneumomediastinum, pneumopericardium, the use of nitrous oxide is absolutely, absolutely contraindicated. Not only that, I will rather say giving nitrous oxide to these conditions means almost inviting the death of the patient. Second important, nitrous oxide is responsible for ozone depletion. Actually, will not say that only nitrous oxide. All inhalation agent they causes ozone depletion, but you have seen that we are using nitrous oxide 75%. So very high concentration. So we'll be releasing high concentrations in atmosphere. So that will cause significant ozone depletion. Xenon, I told you, is actually ready for use, but it is not used because of its cost. It's very, very expensive. Maybe I can say 300 times more expensive than nitrous oxide. So this is the only, you can say, restricting factor for use of xenon. Otherwise, xenon has no side effects like nitrous oxide. Means it is not 35 times more soluble than nitrogen, so it can be safely used, so no risk in such patients. And most importantly, it is not responsible for ozone depletion, so no side effects like nitrous oxide. Halothane, so these two properties of halothane we already have discussed, that it is most potent and it has got slowest induction and slowest recovery. So it's the most potent agent and it has got slowest induction and slowest recovery. Then another important thing about halothane, which you can remember, is that it sensitized myocardium to catecholamines. So sensitized myocardium to catecholamines means in the presence of catecholamines, there is increased risk of arrhythmias. So in presence of catecholamines, there is increased risk of arrhythmia. Then another important thing about halothane, it can cause hepatitis. So among the agents of the current use, you can say which can cause clinically proven hepatitis is halothane. So halothane can cause hepatitis. Isoflurane, what you can remember about isoflurane is that it has got irritating induction. So isoflurane has got very irritating induction. And the advantage is that it is the inhalational agent of choice for cardiac patients because it is most cardiac stable in all cardiac patients, including MI. Including MI. Why? Because in MI patients now it is proven that it does not causes coronary stent. No coronary stent. Previously, actually, we were not using isoflurane in MI patients because we are believing that in MI patients it can cause coronary stent. But nowadays, it is proven that isoflurane does not causes coronary stent, so can be used in all cardiac patients, including MI. Desflurane. Desflurane is an isomer of isoflurane. So therefore, induction of desflurane is also irritating. So desflurane also had got irritating induction. And this thing we already have discussed that it can produce carbon monoxide with desiccated soda lime. So with desiccated soda lime, it can produce carbon monoxide. Then the main advantage of desflurane is that it is minimally metabolized, less than 0.1% metabolized. less than 0.1% metabolized, so it does not produce fluoride. Actually, inhalational agents on metabolism produces fluoride, but since it is negligibly metabolized, does not produce fluoride. And what is the problem of fluoride? That fluoride can cause nephrotoxicity. So it does not produce fluoride, means it is safest from renal point of view, making it as a inhalational agent of choice for renal patients. Making it inhalational agent of choice for renal patients. Sevoflurane is the fourth agent, that is fourth volatile agent which is being used. So sevoflurane is the inhalational agent of choice. IOC means nothing, inhalational agent of choice for pediatric induction. For induction, I told you we are using IV agents. But sometimes the problem in children is that children will come without IV lines because children will not allow us to put IV lines. So we have to directly induce them by inhalation induction, and then we put IV cannulas once the child fall asleep. Since sevoflurane has got smoothest induction, so making it as a inhalational agent of choice for pediatric induction. Then sevoflurane produces maximum bronchodilation. Maximum bronchodilation, making it as a inhalational agent of choice for asthma. And then it is also the inhalation agent of choice for neurosurgery because it causes minimum increase in intraocular, not intracranial pressure. So actually all inhalation agents, they increases intracranial pressure, including sevoflurane. All produces, but increase in intracranial pressure with sevoflurane is minimal. So therefore, making it as a inhalational agent of choice for neurosurgery. Any technical glitch? Wait. Muscle relaxants. Muscle relaxant broadly has been classified as depolarizers and non-depolarizers based on their mechanism of action. So depolarizer that is being used is succinylcholine. Succinylcholine is the depolarizer which is being used, and I told you that it is the ideal muscle relaxant for intubation. Ideal muscle relaxant for intubation. Why? Because its onset is very fast, within you can say 20 to 30 seconds, and duration is also short, that is less than 10 minutes. And why it has short duration? Because it is metabolized by pseudocolinesterase. It is metabolized by pseudocolinesterase. Side effects. The two most important side effects of succinylcholine are hyperkalemia. In fact, the most important I will say is hyperkalemia. And why succinylcholine produces hyperkalemia? You know that. What is the mechanism of action of succinylcholine? Depolarizer. What do you mean by depolarizer? Means it is going to depolarize. So it is going to act like acetylcholine. It is when you give succinylcholine, millions of molecules of succinylcholine will reach at all neuromuscular junctions, producing muscle contraction in all body muscles that you can see as fasciculations. Then why relaxation? Persistent depolarization will make the membrane to become refractory for a transient period. So that period is the period of relaxation. So continuous muscle contractions are going to release potassium, so that can produce hyperkalemia. And these muscle fasciculations are also going to cause myalgia in postoperative period. Non-depolarizers. Non-depolarizers are long acting, so they are used for maintenance of surgical relaxation. Obviously, they are long acting, so they are used for maintenance of surgical relaxation. So presently used non-depolarizers, vicuronium. Vicuronium is most cardiac stable. Vicuronium is most cardiac stable. So obviously making it as a muscle accent of choice for IV patients. If we rapidly revise, which was the most cardiac stable IV agent? Etomidate. Which was the most cardiac stable inhalational agent? Isoflurane. And most cardiac stable muscle relaxant is vicuronium. Atracurium and cisatracurium. Atracurium and cisatracurium, they are unique because they are metabolized in body by Hoffman degradation, which is nothing, this is just a spontaneous degradation. So this spontaneous degradation is called as Hoffman degradation. So Hoffman degradation means spontaneous degradation. So automatically with the time, they keep on getting degraded. Spontaneous degradation. And since they are spontaneously degraded, so there is no risk of accumulation, making them as a muscle laxant of choice for renal failure. They're not dependent on liver for metabolism, spontaneous degradation, also making them muscle laxant of choice for hepatic failure. So they are the muscle laxant of choice for hepatic failure or renal failure. Now reversal. The effect of these muscle laxants should be reversed by giving reversal agent, and the commonly used reversal agents are cholinesterase inhibitors. And among the cholinesterase inhibitor, most commonly used is neostigmine. So what neostigmine or cholinesterase inhibitors do? They inhibit cholinesterase. Inhibiting cholinesterase means that will prevent degradation of acetylcholine. So there is more acetylcholine molecule available at neuromuscular junction to have competitive antagonism with muscle relaxant. But the problem is that this increased acetylcholine is not only going to act on nicotinic receptor, it is also going to act on muscarinic receptor. So there will be muscarinic side effects. So to combat these muscarinic side effects, we have to use a anti-muscarinic agent, and the most commonly used or most preferred anti-muscarinic agent is glycopyrrolate. So this glycopyrrolate I told you is given mixed with neostigmine to prevent muscarinic side effects which occur because of the increased acetylcholine levels. Second reversal agents are gamma cyclodextrins. So the advantage of gamma cyclodextrins is that they directly bind, and they are available in the brand name Sugammadex. So it is possible that they may ask you what is Sugammadex. That's it. So it is also a newer reversal agent which just directly bind to muscle laxant, just form a complex. So you can say it just act like magnet, form a complex, and that complex is removed from body. Gamma cyclodextrins. Now complications of general anesthesia, common complications we will see. Aspiration is considered as preventable complication of anesthesia. Although it is, and this, they have very commonly asked it, that what is the preventable complication of anesthesia? Aspiration. And the best method to prevent aspiration is follow the proper fasting guidelines. And what are the fasting guidelines? For solid food, 6 hours. However, if the food is fatty and non-vegetarian meal, it takes more time. So fasting of 8 hours is required. Clear fluids means just giving water. Clear fluid means water can be given up to 2 hours, while breast milk has faster absorption compared to the top milk, then 4 hours is enough. So fasting recommendations are very important for all kind of surgeries, even if the surgery is minor and you are giving anesthesia, even if surgery is say 5 minutes and you are giving anesthesia, so patient can still aspirate. So if the patient is being given anesthesia, he or she should maintain full fasting, which is 6 hours for solid, 8 hours for fatty or non-vegetarian meal, 2 hours for clear fluids means water, and 4 hours for breast milk. Now, but it is not always possible to prevent, because sometimes the we have to take the patient and they're not fasting, like say emergency laparotomies or emergency surgery, any emergency surgery, we have to take the patient and patient is not fasting. So if you encounter a patient who is at high risk of aspiration, what should be the anesthetic management? If you are giving GA to this patient, that is called as rapid sequence induction. So in rapid sequence induction, there are two different from normal GA. Only two differences. Bag and mask ventilation will be absolutely contraindicated. Normally, after giving muscle accent, we start giving positive pressure ventilation with bag and mask till the effect of muscle accent come. But here, bag and mask ventilation will be absolutely contraindicated. Why? Because I told you that one of the biggest complication of mask ventilation is increased risk of aspiration. And secondly, as soon as patient fall asleep, assistant apply the cricoid pressure. This is called as Salix maneuver. So what the assistant is doing by applying cricoid pressure, he or she is pushing the cricoid posteriorly to compress esophagus between vertebral columns and his fingers. So esophagus get compressed means patient will not be able to aspirate. So in rapid sequence induction, RSI, two important thing from normal GA. Bag and mask will be absolutely contraindicated, and once the patient fall asleep, assistant will apply cricoid pressure till you are able to intubate the patient. CNS complications. CNS complications can be convulsions. And what can be the causes of convulsions? Hypoxia. Then anesthetic agents which can cause convulsions, methoexytone, and that's why it is used for electroconvulsive therapy. Propofol and etomidate also have been found to cause convulsions. So these are the IV agents which can cause convulsions. Enflurane and sevoflurane. Enflurane is obsolete nowadays. So among the current agents, you can say sevoflurane. So these are the inhalational agents which can cause convulsions. And convulsions are also seen in local anesthetic toxicity. So local anesthetic toxicity can also precipitate convulsions. GI complications. GI complications can be nausea and vomiting. And nausea vomiting actually is the most common post-op complication of general anesthesia. So nausea vomiting is the most common post-operative complication of general anesthesia. And why I use green pen? Because previous studies used to say pain to be the most common post-op complication, but recent evidence have found nausea vomiting to be the most common post-op complication. Anaphylaxis. Any drug which we are using in perioperative period can cause anaphylaxis, but the most common cause of anaphylaxis as per recent study is antibiotic. So again, I'm going to use the green pen, because in books you will find that the most common cause of anaphylaxis mentioned is muscle relaxants, and that was true as per the last French study, but the recent British study have shown that the most common cause of anaphylaxis is antibiotics. Thermal complications. Can one of the thermal complications which is although rare but can be disastrous is malignant hyperthermia. Malignant hyperthermia. So what are the agents which can precipitate malignant hyperthermia? Suxamethonium being the most commonly implicated drug to trigger malignant hyperthermia. So suxamethonium or succinylcholine is the most commonly implicated drug to trigger malignant hyperthermia. Then malignant hyperthermia may occur with volatile agents. All volatile agents, they can also trigger malignant hyperthermia, but among volatile agents, maximally it is seen with halothane. So both way this question has been asked. So please don't get confused. If they ask you most commonly implicated drug, it is succinylcholine. If they ask you most commonly implicated volatile agent, then it is halothane. However, all volatile agents, they can trigger malignant hyperthermia. Management of malignant hyperthermia, you know, is dantrolene sodium antidote, or you can say management of malignant hyperthermia is dantrolene sodium. Specific management is dantrolene sodium. Local anesthetics, let me see any technical glitch. Fortunately, nothing. Local anesthetics. So before starting local anesthetics, we need to see the sequence of nerve fibers, because practically it is very, very controversial. Nerve blocks, you know, are maybe central nerve blocks. Central nerve blocks means include spinal and epidural. Central nerve blocks means given along the central neuraxis, that is spinal and epidural. And any block other than given in spine, that is spinal and epidural, is the peripheral nerve block. So for peripheral nerve block, first fiber to be blocked is A, then B, and then C. While for central nerve block, that is spinal and epidural, I told you, first fiber to be blocked is B, then A, and then C. And if they don't mention and they first ask you first fiber, then consider it as peripheral nerve block. If they don't mention, if they most often they mention that this is a kind of block which fiber will be blocked first. If they mention, then it is fine. But if they don't mention, consider at peripheral nerve block, and it should be A, B, C. While central axonal block is specifically if they ask, then it is B, A, C, and the recovery is in reverse order. Means after peripheral nerve block, first to recover will be C, then B, and then A, and central axonal block, first to recover is C, then A, and then B. Functional, in terms of functional, for peripheral nerve blocks, first to be blocked is motor, then sensory, and then autonomic. While for central axonal block, it's opposite. First to be blocked is autonomic, then sensory, and then motor. And there are many factors which are responsible for this sensitivity, like diameter of the fiber, myelination, number of nodes of Ranvier, anatomical location, nearby pH. So many factors are there. So considering all these factors, you can say after peripheral nerve blocks, first to be blocked is motor, then sensory, and then autonomic. While central axonal block, first to be blocked is autonomic, then sensory, and then motor, and recovery is again in reverse order. Means for peripheral nerve block, first to recover is autonomic, then sensory, and then motor. While for central axonal block, first to recover is motor, then sensory, and then autonomic. Fine. And again, if they don't mention anything, consider it as peripheral nerve block. Local anesthetic toxicity. Local anesthetic toxicity, two systems are involved, CNS and CVS. And definitely CNS is the first system which is involved. So actually CNS is involved at much lower doses as compared to CVS. So CNS is involved at much lower doses as compared to CVS. Then another important thing in toxicity, you should know that local anesthetic with adrenaline, if used for ring block of finger, toes, penis, or pinna, there may occur gangrene of these structures because these structures have end arteries. So they are contraindicated for ring block of finger, toes, penis, or pinna. So for these ring blocks, if you are using lignocaine, it must be plain lignocaine without adrenaline. So local anesthetic with adrenaline is contraindicated for ring block of finger, toes, penis, or pinna, because I told you these structures have end arteries. So using adrenaline can cause gangrene. Now just about individual agents, only the very important properties that you should know we are going to discuss. Prilocaine, only thing one which you can remember is that in high doses it can cause methemoglobinemia. However, this methemoglobinemia is only seen at high doses, not at usual doses. Only at high doses it causes methemoglobinemia. Lignocaine, overall, it is the most commonly used local anesthetic. So lignocaine overall is the most commonly used local anesthetic. Duration without adrenaline, plain, the duration is just 45 to 60 minutes. By adding adrenaline, this duration can be increased to 2 to 3 hours. So plain lignocaine without adrenaline, less than 1 hour, 45 to 60 minutes. By adding adrenaline, you can see duration can be increased by 2 to 3 hours. And why? Because you know that adrenaline is going to decrease the systemic absorption. So more drug is available at local site. So more drug available means it is going to act for longer time. It is not being removed from local site by systemic absorption. So from 45 to 60 minutes, simply 2 to 3 hours can be increased. Maximum safe doses you have to know, because if you know the maximum safe dose, then only you can prevent toxicity. Otherwise, how will you know that how much maximum you can give for a block? So maximum safe dose without adrenaline is 4.5 milligram per kg. But when we use adrenaline, our safety margin increases. We can use higher doses and we can safely give 7 milligram per kg. So maximum safe dose without adrenaline is 4.5 milligram per kg and with adrenaline 7 milligram per kg. Now, bupivacaine is another very commonly used local anesthetic, and bupivacaine is only used plain without, you can say, adrenaline. And the duration of action of bupivacaine is 2 to 3 hours. 2 to 3 hours. And maximum safe dose is 2 milligram per kg. So maximum safe dose of bupivacaine is 2 milligram per kg and the maximum duration is 2 to 3 hours. Then one very important thing about bupivacaine you have to remember is cardiotoxicity. Bupivacaine is highly cardiotoxic and cardiotoxicity can manifest in any form ranging from any kind of bradyarrhythmia to any kind of tachyarrhythmia, and ventricular tachycardia is not so infrequent with bupivacaine. Normally you all know that lignocaine can be used for the treatment of ventricular tachycardia while bupivacaine can cause ventricular tachycardia. And if there occur ventricular tachycardia, now the drug of choice is amiodarone. And why I'm using green pen? Because previously, drug of choice for ventricular tachycardia induced by bupivacaine used to be bretylium. But now they have found that amiodarone is better than bretylium. However, the antidote for bupivacaine toxicity is intralipid. So antidote, not specifically for cardiac toxicity, for otherwise antidote for bupivacaine toxicity is intralipid. And how intralipid is going to help? Obviously, it is going to bind the active form of bupivacaine. And considering these side effects of bupivacaine, that is cardiotoxicity, now they manufactured isomers of bupivacaine, that is levobupivacaine and ropivacaine. So these are the S isomers of bupivacaine with less cardiotoxicity. So you can say main advantage of levobupivacaine and ropivacaine is their less cardiotoxicity. So if they're going to ask you about ropivacaine or bupivacaine, obviously they are going to ask you that what is their chief advantage, that they are less cardiotoxic. Now, regional anesthesia means, I told you, regional anesthesia means blocking one of the region of the body. So for that, peripheral nerve blocks and central nerve cell blocks. So among peripheral nerve blocks, brachial plexus block is very commonly given. And of course, brachial plexus is given for upper limb surgeries. For upper limb nerve supplies by brachial plexus. So that is given for upper limb surgeries. And for brachial plexus block, we can actually use four sites. Interscalene. Interscalene means, as the name suggests, between scalene muscle. The disadvantage of this interscalene approach is that usually ulnar nerve gets spared. Ulnar nerve gets spared means it is not suitable for hand surgeries. Then supraclavicular means just above the clavicle. This is the most commonly used approach for blocking brachial plexus, supraclavicular. But the most bothersome complication of supraclavicular approach is pneumothorax, the incidence of which can go as high as up to 6%. So pneumothorax is the most, you can say, bothersome complication of supraclavicular approach. Third is infraclavicular, below the level of infraclavicular, below the level of clavicle, failure rate is very high. So obviously nobody is using. Fourth approach is axillary, means we are blocking brachial plexus at the level of axilla, and usually musculocutaneous nerve is spared. Musculocutaneous nerve get spared means it is not suitable for arm surgeries. It is not suitable for arm surgeries. Then one more block of the you can say among peripheral nerve block, which is very frequently asked in MCQs, is stellate ganglion block. Very favorite block, I will say, for MCQs. So where we want to give stellate ganglion block, what are the indications? Reflex sympathetic dystrophies of the upper limb. And reflex sympathetic dystrophy, you all would have read in surgery that it is a group of diseases which happens because of the sympathetic overactivity of the uh, because of the sympathetic overactivity, and it includes many diseases like Raynaud phenomena, Raynaud disease, pseudocoastodystrophy, uh, Berger disease. So there is sympathetic overactivity, so you have to give the sympathetic block. And sympathetic supply of the upper limb is mediated through split ganglion, so we have to block the split ganglion. Site is the tubercle of transverse process of C6, that is Shagnick tubercle. So at the level of cricoid, you go laterally till the anterior vestibular mastoid. Then you insert your needle, go perpendicular till you hit the tubercle of transverse process of C6, which is called as Shagnick tubercle. At that point, you can inject your drug. How will you know your block is successful? Patient must exhibit all four signs of Horner syndrome. And all four signs of Horner syndrome, you know, are ptosis, meiosis, anhidrosis, and ophthalmos. So four signs of Horner syndrome, you can say are ptosis, meiosis, anhidrosis, and ophthalmos. So blockage of split ganglion, patient should exhibit these four signs. Then you can say yes, your block is successful. Central axis blocks, I told you, given along the central nerve axis. So they include spinal and epidural. Now, some of the important, you can say, applied anatomy that you should know before giving central axis block is, one is the extension of spinal cord. You know that during intrauterine life, the growth of spinal cord is the spinal cord occupy whole of the vertebral column. Thereafter, the growth of vertebral column is more, so spinal cord start ascending. And in infants, it lies at the lower border of L3. There also the growth of vertebral column is more, so it ascends further. And in adults, it lies at the lower border of L. Now, what is the clinical significance? Means we cannot use even L3-4 space in an infant if you are doing lumbar puncture. Because if you are using L3-4 interspace and your needle become capillate, you can cause injury to spinal cord because it is up to the lower border of L3. So you have to use either L4-5 or L5S1. Similarly, in adults also, you have to use any space below L1, L2 because it lies at the lower border of L1. Then very important, which are the structures encountered? Very commonly asked even in FMG exams also. Very favorite, I will say, for FMG exams. 2-3 times they have asked structures encountered when you are doing lumbar puncture. So posterior to anterior, obviously you are entering from posterior side. First to encounter is skin, then is the subcutaneous tissue, then is the supraspinous ligament which connect the tip of, you can say, spinous process, then is the interspinous ligament this which connect the spinous processes, then is the ligamentum flavum which is considered as the yellow ligament of the body, and after ligamentum flavum then there will be dura and then arachnoid, and CSF is present in subarachnoid space between arachnoid and pia. So structure which are encountered, first is the skin, then subcutaneous tissue, then supraspinous ligament, then interspinous ligament, then ligamentum flavum, then dura, and then is the arachnoid. So you have to pierce the 7 structures to reach the subarachnoid space where there will be flow of CSF. Spinal anesthesia, drugs used are lignocaine 5%, but lignocaine is not used nowadays because of the quad equina syndrome. So nowadays we are using is bupivacaine 0.5%, but this is heavy, 5.5% heavy, or you can say hyperbaric. Hyperbaric means specific gravity is more than that of CSF. So drug is heavier than CSF means drug will always try to settle down. So specific gravity is more than that of CSF. So drug will always try to settle down. Systemic effects, the most common side effect is hypotension. Actually, some degree of hypotension do occur in almost every patient. And why there is hypotension, you are causing lumbar sympathetic chain to block. So blockage of lumbar sympathetic chain will lead to venodilatation in the lower limbs and pelvis. So decreasing the venous return, decreasing the cardiac output, leading to hypotension. Then there can be bradycardia. Normally, whenever there is hypotension, there is tachycardia. But in spinal anesthesia, in spite of hypotension, you see bradycardia. Why? Because we have blocked the sympathetic chain. So sympathetic block will lead to parasympathetic overdominance, leading to bradycardia. Then if spinal becomes so high spinal means it has blocked intercostals, it has blocked even diaphragm, or even it drug reaches the cranium, total spinal. So there can be high spinal or total spinal. Total means the drug has reached even cranium, very high spinal. Post-operative complications can be urinary retention. And urinary retention nowadays, you can say, is the most common post-operative complication of spinal anesthesia. So urinary retention is the most common post-op complication of spinal anesthesia. Why I use green pen? Because previously most common post-op complication used to be post-spinal headache. But now the incidence of post-spinal headache has been so drastically reduced that you can say that in current day scenario, the most common post-op complication is urinary retention. Then post-spinal headache is again important, and this post-spinal headache occurs, or this is also called as post-dural puncture headache. Why this headache occurs after spinal? You have made a hole in dura. Through that hole, there will be continuous seepage of CSF, and continuous seepage of CSF will decrease the ICT. Decrease in ICT will lead to shrinkage of brain and meninges. And when brain and meninges get shrink, vessels also get stretched. So basically, it can be defined as low pressure meningovascular headache. So it is low pressure meningovascular headache. And how to prevent this headache? The most important thing is you have to use fine gauge needle and needles which are just pencil tip, that is dura separating. Obviously, this headache occur because of the damage to dural fibers. So we have a special type of needles which are just going to separate dural fibers, not damaging the dural fibers. They are pencil tip needles. So they obviously will cause less trauma, and lesser the gauze, lesser the gauge of the needle, lesser will be the trauma, so less loss of CSF, so obviously headache will be less. And this is such an important factor, no need to remember, but just to give an idea that the incidence of postprandial headache with 26 gauge needle may be just 1 to 3%, while the 18 gauge needle, this incidence can go as 75%. So this is such an important factor. Epidural, the needle use is choice. In epidural, where we are injecting drug outside the dura. Epidural is actually extradural, outside the dura. So epidural also called as extradural because we are injecting outside the dura. And for that needle which we are using is called as Toews needle, and this is the Toews needle you can see. Technique is loss of resistance. There are many methods, but the most commonly used is loss of resistance. Loss of resistance means as soon as you pierce the ligamentum flavum, outside the dura means after ligamentum flavum. So as soon as you pierce the ligamentum flavum, there will be sudden loss of resistance. Now, contraindication for central axial blocks. So what we are going to discuss are the absolute contraindications that you should know. Otherwise, relative is a big list. Absolute contraindications may be raised ICT. Why we can't give spinal raised ICT? If already ICT is high and you give spinal, there will be sudden loss of CSF, and sudden loss of CSF will decrease the ICT, which will lead to shrinkage of brain and coning. And you know that medullary coning will cause immediate death of the patient. Then patient suffering from coagulopathy. So this can cause coning, which can cause even death of the patient. Patients suffering from coagulopathy or anticoagulants. Suffering from coagulopathy or anticoagulants, if there is bleeding, the patient will keep on bleeding, and this bleeding can become large enough to cause hematoma, and this hematoma can compress a spinal cord and can cause paraplegia. So absolute contraindication. Patient refusal. If patient is refusing for treatment, you cannot give by force. So patient refusal is obviously absolute. Severe hypovolemia. We have seen that the most common side effect of spinal is hypotension. And I told you that some degree of hypotension do occur in every patient. So if the patient is already having severe hypovolemia, so you cannot give spinal. Infection at local site. Obviously, if there is infection at local site, you cannot introduce infection inside the meninges from outside, causing meningitis. Patient with severe fixed cardiac output lesions. Fixed cardiac output lesions means aortic stenosis or mitral stenosis. Aortic stenosis or mitral stenosis. What is the problem in fixed cardiac output lesions? In fixed cardiac output lesions, if you give a spinal, there will be hypotension, and these patients have fixed cardiac output lesions, so they cannot increase their cardiac output in response to hypotension. Let me see any technical glitch. No, great. So specialty management, cardiac patients, specialty management means specific disease management. Cardiac patients, we can give regional anesthesia, safe. If we are giving GA, we have discussed the properties, just it is, you can say, is revision. For induction, what we are going to use? Etomidate, most cardiac stable. For maintenance, most cardiac stable inhalation agent, isoflurane. Muscle relaxant, most cardiac muscle relaxant is vicodinium. For respiratory patients, obviously we will avoid touching the respiratory system. So if a surgery is possible under regional anesthesia, that will be preferred over GA. But all such are not possible under regional, so sometimes we have to give GA. So if you are giving GA, induction is propofol. Ketamine, I told you, is only reserved for uncontrolled asthmatics. Otherwise, propofol is a good bronchodilator. So for normal controlled patient, you can safely use propofol. Maintenance, sevoflurane, I told you, maximum bronchodilation. Muscle accent, you can use anyone. However, they say steroidal kind of muscle accent are preferred because they do not release histamine. Hepatic patients, anesthesia of choice is GAY because hepatic patients, they may be having coagulopathy, and coagulopathy is a contraindication for regional anesthesia. So GA. During GA induction, hepatic or renal patient, what you prefer? A drug with shorter half-life. So propofol has shorter half-life, so we'll prefer propofol. Maintenance, sevoflurane. Why? Because it causes minimum decrease in hepatic blood flow. Actually, all these inhalation agents, they decreases the hepatic blood flow. Minimum decrease in hepatic blood flow is seen with sevoflurane. Muscle relaxant. Muscle relaxant will be cis atracurium or atracurium because they are metabolized by Hoffman degradation, so they are not dependent on hepatic functions. Renal, for renal patients, obviously you cannot give regional. Why? Because to treat regional anesthesia or to treat hypotension, we have to give fluids, and we cannot give fluids in renal patients, otherwise they will develop pulmonary edema. So anesthesia of choice is GA. During GA, again induction propofol. Why? Short half-life. For renal or hepatic patient, we prefer short half-life, that is propofol. Muscle relaxant, maintenance, desflurane. Why? Because I told you it does not produce fluoride. So safest from renal point of view. Muscle relaxant, again atracurium or cisatracurium because they are metabolized as Hoffman degradation. So there is no risk of accumulation. Neuromuscular disease patients, or you can say myasthenia gravis or muscular dystrophy patients. The problem, if patient is suffering from some muscular disease, obviously the patient is going to exhibit abnormal response to muscle relaxant. So our aim should be to avoid muscle relaxant. Avoiding muscle relaxant means avoiding GA. So anesthesia of choice will be regional. But again, all surgeries are not possible under regional. So sometimes we have to give GA. So during GA, induction is propofol, short half-life, maintenance. In fact, any volatile agent you can use, desflurane or any agent based on your availability and personal choice. Muscle relaxant, obviously, we will prefer a muscle relaxant which does not have risk of accumulation. That can be mivacurium because mivacurium is also metabolized by pseudocholinesterase, but this is generally not available, so I did not mention also. So obviously safe will be cisatracurium and atracurium because they also do not have any risk of accumulation. Suxamethonium is absolutely contraindicated for muscular dystrophy patients because these patients are at very high risk of malignant hyperthermia. Muscular dystrophy patients are very high risk patients for malignant hyperthermia, and we have seen that suxamethonium is the most commonly implicated drug to trigger malignant hyperthermia. Neurosurgical anesthesia. Induction agent of choice is thiopentone. Why? Because I told you that thiopentone is cerebroprotective. Maintenance is sevoflurane because I told you minimum increase in intracranial pressure. And muscle accent, you can use any non-depolarizer, not an issue. Avoid suxamethonium. Why? Because suxamethonium also increases the intracranial pressure. So suxamethonium, by causing fasciculation of this neck muscles, will obstruct the jugular, decreasing venous return from brain, increasing the ICT. Obstetric anesthesia, very common, maximum patients we are getting for obstetrics, and they do come to us for cesarean section. Choice of anesthesia is beyond any second thought spinal. Avoid GA because of the increased risk of aspiration. Pregnant patients are actually 8 times more vulnerable for aspiration. Reason? Because the most important factor which maintain or prevent aspiration is the tone of lower esophageal sphincter. So this lower esophageal sphincter becomes incompetent in pregnant patients due to progesterone, and gravid uterus compresses the stomach. So angle is lost. So LAC is incompetent, 8 times more riskier. So even if you are giving GA, always give GA with rapid sequence induction. A pregnant patient, even if she is fasting, should be considered as full stomach patient. So all pregnant patients, irrespective of their fasting status, should be considered as full stomach. Then another important thing, if there occur hypotension in pregnant patients, we are using vasopressor. Normally, we are preferring ephedrine. However, in pregnant patients, phenylephrine is preferred over ephedrine. This is recent, so I'm using green pen. Why phenylephrine? Because it causes minimum vasoconstriction in uteroplacental circulation. So minimum vasoconstriction in uteroplacental circulation means there is least compromise in vascular supply of the fetus. So phenylephrine is preferred over ephedrine. PIH patients. Another important thing, previously for PIH patients, we were avoiding spinal, but nowadays anesthesia of choice for PIH patients is spinal. Actually, why we avoid spinal in PIH is what? Pregnancy-induced hypertension, and hypertension is one of the relative contraindication for spinal. Why? Because it has been seen that hypertensive patients, they have lost the normal hemostasis of BP maintenance. So spinal, they can go in sudden hypotension. So that is why we were avoiding. However, recent evidence have found that it is not that significant. So you can safely use spinal even for PIH patients. Second group that is coming to us is they are coming for painless labor. Painless labor, the most preferred is lumbar epidural. So in epidural space, we place a catheter, and through that catheter, throughout the labor pain, we keep on giving continuous infusion of the drug. So lumbar epidural. If that is not feasible, then the second option can be Entonox. Entonox, I told you, is 50% oxygen, 50% nitric oxide. So labor patients will keep on inhaling this Entonox. Pediatric patients. Pediatric patients, if we are given GA, mostly we are giving GA. Now regarding their induction, very important. Many tricky questions you see regarding the induction. I told you first choice of induction is always IV. So even for pediatric, first is IV, that is propofol. But the problem is that propofol, this many patients I told you, they are coming without IV cannula. So if IVSS is not available, then only we go for inhalational induction. And inhalation induction of choice, I told you, is sevoflurane because it has got smoothest induction. And the second choice is halothane, that's it. Isoflurane and desflurane, I told you, they can never be used for induction because if you remember, although difficult to remember, that isoflurane and desflurane have got irritating induction, so they cannot be used. So many questions regarding pediatric induction has been asked. So if propofol is the choice, that is the first. If IV not possible, then Sevo is the first choice among inhalation, and halothane second and last. ISO and DES can never be used. Daycare surgery, very common. And when you are giving daycare surgery and patient is being given GA, The important is the drug selection. Although they say preferred is laryngeal mask care, we want to avoid the complications of intubation. So prefer is LMA, but that is preferred, not that we cannot intubate, we can intubate. So important is not that we are putting LMA or intubating. Important is your drug selection. IV agent which we are going to choose is propofol. Opioid which we are going to choose is remifentanil because it is also ultra short acting. Inhalational agent of choice that we are going to choose is sevoflurane. Although desflurane has fastest induction, I told you, but desflurane's side effects are many, irritating induction, environmental hazard, cost-wise very expensive. So considering all these factors, sevoflurane is preferred. Muscle accent, mivacurium, because it is again short acting. And benzodiazepine of choice is again midazolam because it is also short acting. But mivacurium is generally not available, but yes, of course, it is the muscle action of choice for daycare surgery. So IV agent of choice for daycare surgery, propofol, opioid remifentanil, inhalational sevoflurane, muscle action mivacurium, and benzodiazepine is obviously midazolam. Anesthesia for laparoscopy. Laparoscopy is really getting very, very popular. You would see that there are many surgeries done under laparoscopically. Although the ideal gas is argon because it's inert. For laparoscopy, they have to insufflate the abdomen with the gas. Argon is ideal because it's inert, no side effects, but argon is too expensive to afford. Even in West, they are not able to afford argon. So therefore, most preferred gas is carbon dioxide. Carbon dioxide, why? Because it has got high diffusibility. High diffusibility means wherever it goes, it get absorbed from that circulation within half an hour. So carbon dioxide is most preferred. And the most important thing you have to take care during intra-abdominal surgery is that ensure that when they are insufflating the abdomen, intra-abdominal pressure should be maintained between 12 to 14 mmHg, not beyond 40. Otherwise, if there occurs significant increase in intra-abdominal pressure, that can lead to compression of IVC, that can decrease venous resistance so much that it can cause even cardiac arrest. So never allow this intra-abdominal pressure to go above 14. So don't allow this intra-abdominal pressure to go above 14 mmHg. Technical glitch? No. Great. Critical care, very important. Oxygen delivery devices. Very frequently asked. Means every exam for last 2-3 years or 4 years, whether it is FMG, All India, NICT, they are asking about oxygen delivery devices, maximum flow which you can use, or what is the maximum output. So oxygen delivery devices, maybe nasal cannula. This is nasal cannula. This is simple oxygen mask. This is oxygen mask with reservoir, and this is venturi mask. Fine. So what is the maximum oxygen output and maximum flow? I told you every exam in last 3 years, you have a question from this table. So you have to just mug up. So with nasal cannula, maximum flow you can use is 6 liter because at 6 liter per minute, you get the maximum output of FiO2 delivered oxygen. That is 0.4 means around you can say 40%. That is the maximum output. Oxygen mask, so nasal cannula is 0.4 maximum. Simple mask, this is simple mask, maximum flow you can get is 10 liter. And at 10 liter maximum output is 0.6, that is 60% of the oxygen. So maximum you can get is 0.6 FiO2. However, with reservoir, you can give up to 15 liter and the maximum output is 0.8, that is 80%. 0.8. And venturi mask, maximum flow you can use is 15 liter and output is 6%, that is 60%. So this is venturi mask. Again, the output is 0.6 maximum. So this is a very important thing because And why it become popular? Because of the oxygen crisis that occur in COVID. I've seen people with simple oxygen mask, nasal cannula using 15 liters and just wasting the oxygen because their maximum output is at 6 liter. After that, whatever you give with oxygen mask 10 liter, whatever you give, output is not going to go beyond zero point 0.4 with nasal cannula and with more above 60% with oxygen mask. Then non-invasive ventilation. That also is important that you should know. So generally we think ventilation means we are just intubating the patient. No, you can ventilate the patient without intubation by putting a tight fitting mask. This is non-invasive ventilation. Advantages. The most important advantage is decreased incidence of ventricular associated pneumonia. Well, and disadvantage is claustrophobia. You can see tight fitting mask. It has to be very tightly fitted. So that can cause claustrophobia to the patient. Now, the most important thing, if you get a question related to ICU, oxygen management, either it will be through non-invasive ventilation or and non-invasive ventilation most commonly used for type 2 respiratory failure. Although during COVID we tried for type 1 also, but mainly it is used for type 2. Type 2 means CO2 will be high, hypercapnic respiratory failure. So it will be either from this table, maximum flows, or maybe non-invasive ventilation. Mainly they can expect that what is the advantage, disadvantage, and it is used for what kind of respiratory failure, or from lung protective strategy, very important. Because whatever the mode of ventilator you use, whatever the kind of ventilator you are using, whatever the cost of ventilator you use, that do not define your mortality or morbidity. It is the lung protective strategy which define morbidity and mortality. So lung protective strategy, there are four basic components. Tidal volume, low tidal volume. Low tidal volume means by definition 4 to 6 ml per kg of the ideal body weight, not normal body weight. 4 to 6. Normal tidal volume is how much? 10 ml. So we have to use low tidal volume, 4 to 6 ml. Plateau pressure less than 30. And why they choose plateau pressure, not peak pressure? Because plateau pressure indicates pressure at alveolar level and barotrauma occurs at alveolar level. So we have to monitor the plateau pressure. PEEP is the positive and expiratory pressure. Means we are giving positive pressure at the end of expiration. Normally what happens during expiration, alveoli collapses. So if you give positive pressure during expiration, alveoli will remain open during expiration. So gas exchange will take place even during expiration. But all the time positive pressure means increased risk of barotrauma. So they say start with minimum PEEP of 5 centimeter and titrate. So these strategies are there to prevent lung against barotrauma. So these lung protective strategies, low tidal volume, monitoring of plateau pressure and low PEEP is to decrease the incidence of barotrauma, or you can say to protect the lung against barotrauma. Second is lung can get damaged by hyperoxia and oxygen induced toxicity can cause irreversible ARDS. So FiO2 should be less than 0.6% and this is obviously to prevent oxygen toxicity. So lung protective strategy means to prevent lung against barotrauma and to prevent lung against oxygen toxicity. So these are the four components which you must know. Very high chances to get a question on it. CPCR, cardiopulmonary cerebral resuscitation. So AHA 2020, I'm not going much details. You would have read it many places. So just the summary of changes as per 2020 guidelines. You know, there are three chains of survival before 2020. Basic life support, advanced cardiac life support, post cardiac arrest care. Now they have added the fourth chain of survival, that is recovery. Means your recovery means patient should be fully recovered. You have to take care of the damage which has suffered. That can be cognitive dysfunction, motor dysfunction, behavioral dysfunction, all those things has to be taken care. Adrenaline, as soon as possible means they say within 3 to 5 minutes. Because adrenaline given in less than 5 minutes and after 5 minutes, there has been difference in the prognosis. Layman, for common man layman, they say pulse check is not expected. That doesn't mean they will not do pulse check. But if they are not able to say with surety that pulse is there or not, no problem. If they're not able to palpate, they can start CPR. Audio visual feedback means to see the performance of your CPR, they say that you should have audio visual devices, but that is not practically possible. They will tell you that what mistake you are making during CPR. And in pediatric CPR, they made a most important change. Now the respiratory rate for pediatric age group during CPR is 20 to 30 breaths per minute, which used to be 10. So this I will really say the most substantial change in CPR is respiratory rate for pediatric age group, which used to be 10 per minute. Adult, it is still 10 per minute, but for pediatric, it is 20 to 30 per minute. Then another important change, intraosseous. Intraosseous means into the bone, and the most commonly used cavity is medullary cavity. Most commonly used is bone is upper end of tibia, and the most important change they have made is that now intraosseous is preferred over endotracheal. Previously, endotracheal route was preferred. Anything can be given. Anything means you can even give blood transfusion through intraosseous route, and you would have seen intraosseous set. A big steel needle is there that is pierced into medullary cavity and connected to any of a IV line, and can be used at any age. Previously, intraosseous is only used for children less than 6 years, but now they can be given at any age. And that's all. So now let me go through the queries or comments. So I'm going to YouTube. Let's see the chat. Okay. Shabina Parveen, sir, is this enough for anesthesia? Yes, largely, Shabina. See, just 2.5 hours, I cannot guarantee that you will be having 100% questions, but looking at the trend of FMG questions in the past, yes, I think, if not all, then you can say I think 90% of the questions should be from this 80 to 90% questions. Yeah, Vishal held it 2.5, I corrected it 3.5. Yes, right result. Yes. Happy Diwali, Sunil. Why there is dissociation with ketamine? Actually, the reason for dissociation is actually ketamine causes you can say uh, stimulation of limbic system and inhibition of cortex. So inhibition of cortex, unconscious, stimulation of limbic system causes vivid reactions. So patient, you can say CNS is dissociated. So patient get dissociated from himself or herself. So which pathway is affected in brain? I told you with ketamine causes inhibition of cortex and stimulation of limbic system. Ketamine causes bronchodilation receptors. Actually, bronchodilation by ketamine is exactly not clear, but most probably they say it could be central or could be because of sympathetic stimulation. Because parasympathetic, causes bronchoconstriction and it causes sympathetic stimulation. So this bronchodilation may be because of sympathetic stimulation. So lecture के बाद PDF मिलेगा क्या? Abhishek, I can give PDF, but I don't know with the YouTube session how I'm going to give PDF. I made a copy you would have seen in the beginning so that I'm keeping this annotated PPTs. So I don't know. For me, no problem. I can give annotated PPTs, but are you a regular student? Let me know if it can be posted on Telegram group or somewhere. So definitely, if it is there, I'll give no problem. But just let me know how to give this annotated PPTs. Sunil Raman, long time surgery for use. So Sunil, I did not get your question. Long time surgery for use. And what is this 0.1% what you have asked? So can you repeat? Long time for use of surgery. I did not understand, Sumitra. And what is this 0.1% also did not understand? Text 6. Text is a special vaporizer that is used for desflurane. Vaporizer is a very big topic. So I did not, actually that much details are not required for you. Just if you can remember that vaporizer used for the delivery of volatile agent, that should be enough. So text 6 is a special vaporizer which is used for desflurane. Sweet slowly for PDA use. Okay, that is sevoflurane. Hepatically, yes, sevoflurane, minimum decrease in hepatic blood flow. Dantrolene sodium action. This myelin hyperthermia occurs because of the release of calcium. So that calcium release is inhibited by dantrolene sodium. So at cellular level. I told you bupivacaine is cardiotoxic. I described, and that can manifest in any form ranging from any kind of bradyarrhythmia to any kind of tachyarrhythmia, and ventricular tachycardia is also common with bupivacaine. CO2 more diffusible or nitrous oxide? Actually, CO2 is definitely more diffusible in all tissues, all cavities. When to increase or decrease PEEP or FiO2? Vishal, actually this depends. Uh, See, ICU management is a very, very big topic. It is now, it is a super specialty. So it depends. See, PEEP, I told you that, okay, let me go to this slide of lung protective strategy. We will keep on increasing PEEP, but ensure that plateau pressure is not going beyond 30. If it is within less than 30, see, we are guiding by blood gas analysis and oxygen saturation. If patient SpO2 or PO2 is increasing, we can keep on increasing PEEP until and unless it doesn't go beyond 30. But even if it is going beyond 30, so we cannot increase now PEEP. We have to stop PEEP. Say, I'm giving, say, 12 PEEP and still uh, plateau pressure is 25. So no problem. I can safely give if patient is maintaining oxygenation. If at 12 peep say plateau pressure is coming 32, so I cannot. So what I will do, I will have to take risk. I have to play with this. So this is all risk benefit ratios. Right? Correct. And Mohan Raj has said, yes, increase PF if you want to increase oxygenation. FiO2 also will increase oxygenation, but we have to balance the risk. So I think Vishal, that is clear. For cardiac patients, we prefer etomidate, neither ketamine nor propofol. Propofol causes hypotension, ketamine causes sympathetic stimulation, which is not good for cardiac patients. How it causes rigidity, Mohan Raj? This rigidity is again central because of the mu receptors. So this rigidity is mediated by mu receptors. Uh, Shailesh Jain, sir, Telegram link please send. So Sailesh, I will send the Telegram link, but where? You need to send me some Telegram message. So accordingly, I will send you the Telegram link. So let me see any other queries. Okay, Vishal, they has also asked, uh, Okay, for NEET it is covered. One short revision. I don't think that NEET it has been covered till now. For this NEET, I don't remember it is covered. I don't think it has been covered. Yes, Vishal, I told you, if blood pressure is more than 30, then we have to play with change in FiO2, or there are certain other strategies we can apply, change in I ratio. There are many other things before changing FiO2, but I didn't go in that much details and not required for you also. Mohan, is the same mu receptors lead to constipation in opioid? Correct. Same mu receptor. Actually, mu receptors are distributed everywhere. They are in CNS, they are in spinal cord, they are in extra site like in GIT, they will cause constipation. So constipation will be mediated by mu receptors present in GIT. Then urinary retention may be because of the present in bladder or maybe in spinal cord. So there are mu receptors, these opioid receptors are spread at CNS site as well as a lot of extra CNS sites. So any other doubt? Correct, yes, Mohanlal. That's what I was saying. Lead to pressure should not be 30. If it is going more than 30, then we have to see, and accordingly we have to, I told you we have to change I ratios, and then if that also doesn't work, then we have to even play with the FiO2. Okay. Any other doubt? I'll just wait for 1 or 2 more minutes. Still there are more messages. Fine. If not, then I'll close the session. Salesh Jan Telegram link. Just give me a second. I'll try to post it here. Just give me a second. I'm going to Telegram link to copy it. I think there is some issue. I don't know why I'm not getting link. There is some issue. I'm not getting link actually. I try. I don't know. I'll do it later, no problem. I'm not getting link. Just a second. Let me try again. I think there is some issue with Telegram. I'll send you later, I think. I'll try to send you later. I think there is some issue. I don't know why I'm not getting link. Some issue. I think I had my two phones on that, so there was some issue is coming. So I'll send you later, no problem. I'll try to send the link. I will try. There is some issue. Okay. Fine. Anything? So should I close? I think nobody is typing. So okay. Fine. Fine. Okay. Okay, then I'm closing the session.